Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Our lecture today about uterine transposition. And before I start, I try to explain the title of this lecture. We are trying to change the position temporarily of the uterus and the adnexy from being a pelvic organ to be abdominal organ. Why? To be away from radiation field in case a woman or a girl with rectal cancer, anal cancer, and they need radiotherapy, which is injurious to the ovary and the uterus. So we want to put this uterus and the ovaries and the adnexy away from radiation field. So we change the position to be abdominal. Okay, this is the idea of this lecture. Let's start. What are the objectives? We'll take an introduction about this subject. Ovary and radiotherapy, uterus and radiotherapy, fertility preservation methods, displacement of the uterus, either uterine transposition or ventrofixation. Then the core of our lecture, which is uterine and adnexal transposition. Okay, let us start. This is a case report published by Professor Ribeiro and his colleagues, 2017. This is a case report about uterine transposition, and he is a leader in this operation. Okay. Also, this lecture guided by another study published 2024 by Professor Ribeiro from Brazil and his colleagues. Also, another study, systematic review, published 2024 about uterine transposition in comparison to uterine ventrofixation before radiotherapy as a fertility sparing option in young women. Okay, so let us start our lecture. So chemoradiation may be required treatment in young women with pelvic malignancies. As I said before, rectal cancer or anal cancer or vaginal or cervical cancer. So radiotherapy or chemoradiotherapy may be needed in such young women. Okay, irradiation may result in ovarian and uterine failure, compromising the fertility of those patients. Okay, while ovarian transposition is an established method to move the ovaries away from the irradiation field, similar surgical procedures regarding the uterus remain investigational. The average age for first pregnancy is going to rise due to the cultural and social changes, making the issue of fertility sparing surgery a relevant clinical need. So what is the relation between ovary and radiotherapy? What are the hazards and risks of radiation on the ovary? Oocytes are highly sensitive to radiation. A dose of 2 gray can destroy up to 50% of oocyte population. Okay? The dose that may cause immediate and irreversible ovarian failure change with the age. What does it mean? The dose that can cause permanent damage in the ovary and ovarian failure is different with different ages, from birth, girls, adolescent, adult, and so on. For example, at birth, 20.3 gray is the dose that can cause permanent damage to the ovary. At the age of 18, the dose is 18.4 gray. At the age of 20, the dose is 16.5 gray. At the age of 30, 14.3 gray. So as you see here, with advancement of the age from birth to the childbearing age and up, the dose of irradiation that can cause permanent damage to the ovary is lower with the advancement of the age. At birth, 20.3 gray can damage the ovary permanently, while at the age of 30, 14.3 gray. Okay? What about the uterus and the radiotherapy and the risks of radiation on the uterus? There is a few data on the radiation dose causing permanent loss of uterine function. But some authors stated that the maximum uterine radiation dose compatible with pregnancy is 14 gray. So what are the risks of radiotherapy on the uterus? Reduced uterine volume, impaired uterine distensibility owing to myometrial fibrosis, endometrial injury, uterine vascular damage. So all those are possible risks if one exposed to radiotherapy due to pelvic malignancy. Okay? Okay, what about fertility preservation? For women with pelvic tumor who need radiotherapy, the only available option, documented one, for fertility preservation are oocyte and or embryo freezing and ovarian transposition. You know, ovarian transposition, we are changing the position of the ovaries from being pelvic to be abdominal, away from radiation field. Which might preserve reproductive and hormonal function, respectively. So, oocyte and the embryo freezing preserve the reproductive function only. Okay? But ovarian transposition preserve the hormonal function also. Okay? Although ovarian tissue cryopreservation and transplantation are possible, they are still experimental. Okay? So, what else can be helpful? Displacement of the uterus from the pelvis. And we have two main approaches. Either uterine transposition or uterine ventrofixation or suspension. Okay? And our lecture today about uterine transposition. But to have some information about uterine ventrofixation, uterine ventrofixation has to be preceded by ovarian transposition, and it includes two different options: as suspension that can be obtained using the round ligaments, or directly ventrofixating the uterine fundus to the abdominal wall. So uterine ventrofixation should be preceded by ovarian transposition first. Then we want to fix the uterus to the anterior abdominal wall, either by fixation of the round ligament or by directly fixing the uterine fundus to the abdominal wall. Okay? And there is studies comparing uterine transposition and uterine ventrofixation. Let us go to the core of our lecture today, uterine and adnexal transposition. Uterine and adnexal transposition to the upper abdomen before radiotherapy might protect these organs, and subsequent repositioning of the uterus into the pelvis might allow the patient to experience a normal pregnancy. So, you are changing the position of uterus and the adnexal to be abdominal, then do repositioning for the uterus into the pelvis after finishing the radiotherapy. Okay? This operation is done in two procedures. First procedure, then second procedure. Uterine and adnexal transposition. Okay, look to this picture, please. This is the anterior view of the uterus and the adnexal, and this is the posterior view of the uterus and adnexal. Okay? Okay. I'll summarize the operation, then I'll say it in details. Using 4 ports technique at the umbilicus, the laparoscope, and another port 2 centimeter cranially and medially to the anterior superior iliac spine on each side, and another port suprapubic 8 to 10 centimeter below the umbilicus. Then we are going to free the uterus, to make the uterus mobile by dividing and the coagulation and transection of the round ligament. This is the round ligament on both sides, opening the anterior leaf of the broad ligament and the section of the uterovesical space down till 1 centimeter below the cervix. Then sectioning of the gray zone of the posterior broad ligament till uterosacral ligament. This is the uterosacral ligament. Okay? Then transection by bipolar of the uterine vessels on both sides, and coagulation of the pericervical vessels and the uterosacral ligaments, and transection of the uterosacral ligaments. Now the uterus is free from the round ligament and from the uterosacral ligament, and the main supply uterine artery is coagulated and transected by bipolar coagulation. Okay? What else? Dissection of the infundibulopelvic ligament. You see, this is the infundibulopelvic ligament, or somebody call it suspensory ligament, containing the ovarian vessels. So, dissection of the infundibulopelvic ligament. Now, the uterus is mobile except from the vaginal fornices. So, we open the vagina and deliver the cervix, and now the uterus is mobile, and close the vaginal stop with interrupted stitches. Okay? Okay. Then we are going to continue to dissect the ovarian vessels high up. Okay, then we are going to change the position of the uterus with the adnexy. Imagine this is the fallopian tube and the ovary to be upper abdominal in the upper abdomen, and the cervix through the umbilicus as a stoma. Okay, will be fixed to the sheath here of the anterior abdominal wall or fascia of the anterior abdominal wall. Okay, so the menstrual flow will come out here. Okay, I can test the perfusion of the cervix easily. Okay, this is the idea of the operation, to change the position of the uterus and adnexy to be abdominal away from the site of radiation. After finishing the radiotherapy, then we will cut the adhesions from anterior abdominal wall, and we will repositioning the uterus into the pelvic area again, and the cervix will be fixed in the vagina again, and round ligament will be fixed to the sides of pelvic wall, and the broad ligament will be reconstructed and fixed also to the lateral pelvic wall. This is the second procedure of the operation. The first is to put the uterus in the adnexy abdominal. The second procedure is to reposition the uterus and the adnexy down here in the pelvis. This is simply the operation. Let us go to the details. The patient is placed in dorsal modified lysotomal position, as you see in the picture, with arms placed alongside the body. Urinary catheter is placed and the uterine manipulator is inserted. Uterine manipulator is inserted. This is the uterine manipulator, and this is the laparoscope, and this is the instrument. Okay? What else? After insufflation or pneumoperitoneum, we are going to place 4 ports. One at the level of the umbilicus, 11 millimeter. Look to this picture, please. This is a bigger one. So 1 port for the laparoscope at the umbilicus, 11 millimeter. 2 ports laterally at the point 2 centimeter above and medially to the anterior iliac, superior iliac spine. This one and this one. This is 5 millimeter. Okay. Another port 8 to 10 centimeter from the umbilicus downward, suprapubic, also 5 millimeter. Okay. So we'll start the operation with these ports. 1 for laparoscope and the other 3 for instruments. Okay. For the pelvic part of the first procedure, the surgeon is on the patient's left side. Be careful about the position of the doctor and the assistant because it will be changed later on. We'll start the operation, the surgeon on the patient's left side, the first assistant on the right, the second assistant between patient legs, and the scrub nurse lateral to the patient's left leg. After the patient is placed in Trendelenburg position, the surgery starts with transection of the round ligament at the pelvic side wall. Then the anterior leaf of the broad ligament is open until it reaches the uterus. The gray area of the posterior leaf of the broad ligament is open, and the posterior leaf of the broad ligament medially sectioned up to the uterosacral ligament. The zygotrine space is dissected approximately 1 centimeter distal to the cervicovaginal junction to allow vaginal section. The uterine vessels are coagulated along the junction to the cervix with bipolar energy and then cut. The pericervical vessels and the insertion of the uterosacral ligaments were coagulated and dissected until the full vaginal circumference was accessible for cutting. A colpotomy ring is inserted and the uterus is amputated from the vagina with the use of monopolar energy. In the cut mode, the vaginal cuff is closed by means of separate stitch of absorbable suture like polyglactin 0. Okay? What about infundibulopelvic ligament? It is dissected up to their intersection with the iliac vessels with the use of ultrasonic energy. So, we will dissect the infundibulopelvic ligament up to their intersection with the iliac vessels with the use of ultrasonic energy. Care is taken, which is very important. Care is taken to avoid grasping fallopian tubes or infundibulopelvic ligaments or uteroovarian ligament or what's called ovarian ligament. Why? To prevent damage to the vascular supply to the uterus and the ovaries or damaging the tubes and potentially contributing towards success in future fertility. So this is very important. Don't grasp the fallopian tube or infundibulopelvic ligament or uteroovarian ligament. The uterus is now completely mobilized along with the adnexia and the pelvic portion of the infundibulopelvic ligament. The team is then repositioned. So they are going to change their position for the retroperitoneal dissection of the ovarian vessels and the positioning of the uterus in the upper abdomen. So, what is the change in position? The surgeon moves to the patient right side. The first assistant to be between the patient legs. The second assistant to the left side. And the scrub nurse lateral to the patient's left leg. What also changes? The camera. The camera is placed in the suprapubic trocar and the patient is kept in Trendelenburg position. A 10 millimeter suprapubic trocar is used as a camera port. Okay, the omentum and the bowel are placed on the upper abdomen. The dissection of the left gonadal vessels start with the mobilization of the sigmoid and the left colon by means of lateral to medial dissection with the use of ultrasonic energy. It is important to mobilize the left colon up to the inferior mesenteric artery medially and to the level of the kidney hilum cranially. Subsequently, the left gonadal vessels are gently dissected up to their origin with the use of ultrasonic energy. The same step is repeated on the right side after lateral to medial mobilization of the right colon and cecum. On the right side, the colon is mobilized along the garota fascia up to the level of the duodenum cranially and to the level of the vena cava medially. The right gonadal vessels are dissected, completing the full mobilization of uterus and adnexia. The uterus is then transposed to the upper abdomen. As the uterus is positioned to the upper abdomen, the patient is placed flat, and the bowel is returned to the inferior abdomen through the arch formed by the uterus adnexy and the uterine vessel. So when I get the uterus adnexy up, there is arch down. So the bowel is returned to this arch, this area. Okay? Okay. Ground ligament are sutured, two round ligaments, one on each side, are sutured to the anterior abdominal wall with the use of trans-abdominal non-absorbable, like nylon, 30 suture. Okay? The same trans-abdominal suture is used to attach the peritoneum overlying the gonadal vessels to the anterior abdominal wall to avoid displacement of the uterus or infundibulopelvic ligament, which could cause internal herniation. These sutures are tightened as the pneumoperitoneum is deflated. Remember this point because it is important. Pneumoperitoneum should be deflated first, then tighten the suture. Why? Because if you did it while there is still pneumoperitoneum, this may cause rupture or spasm for gonadal vessels. So these sutures are tightened as the pneumoperitoneum is deflated to avoid traction of the gonadal vessel causing rupture or spasm. Before tightening the suture, the cavity is inspected for abdominal secretions or bleeding, followed by irrigation for cleaning any remaining fluid. Once the pneumoperitoneum is deflated and the transabdominal suture tightened, the umbilical incision is enlarged and the cervix anastomosed to the fascia of the anterior abdominal wall by means of 6 separate polypropylene non-absorbable sutures, 30. Here I want to tell you something. In some authors reported operations in which the cervix is kept inside the abdomen, but the patient previously take suppressing hormone therapy. Okay, so we will induce amenorrhea or suppression of menstruation by hormonal therapy like GnRH agonist therapy, for example. If we suppress the menstruation, we can keep the cervix inside the abdomen. So this is reported by some authors. So what I'm talking today with you is the cervix will be a stoma at the umbilicus. So the menstrual flow can occur normally and the menstrual blood can come out. But some authors reported to keep the cervix inside and they fix the cervix by suturing to the paracolic gutter in the hypochondria. Okay? But in our lecture today, I'm talking about the cervix is fixed on the umbilicus, forming the stoma, and the menstrual flow can occur. Okay? Okay. And this is a good document that there is preservation of the blood flow to the uterus and the ovary, and everything is doing well. If the menstrual flow coming, so the ovary function is doing well, and the uterus is doing well. Okay? Okay, let us continue. Exposure of the cervix through the umbilicus will allow immediate perfusion evaluation at any time, as I said before. The risk of peritonitis doesn't appear to be relevant because peritonitis is a very rare complication of any stoma. Allowing the patient to have normal menstruation through the umbilicus offers proof of uterine and ovarian function preservation, as I said before. Okay. Visual inspection of the cervix is performed twice per day. In your follow-up in the hospital, you are doing visual inspection of the cervix twice per day. Okay? Uterine perfusion is assessed every 2 days by means of Doppler ultrasound of the ovarian vessels. So every 2 days you should do Doppler ultrasound on the ovarian vessels and inspect the cervix twice per day. All of these to know that there is perfusion, good perfusion, good blood supply to the ovary and uterus and cervix, of course. The patient can be discharged after a few days, in some reports 4 days or 5 days, so on. Then the radiotherapy for pelvic malignancy can be started after 10 days on average accordingly. After the end of radiotherapy, we are going to the second procedure or organ reimplantation. So the second procedure for organ reimplantation, I mean to bring the uterus to become again pelvic organ as before, okay, together with the adnexia. The patient is prepared as for the first procedure, but this time the first trocar will be inserted is the suprapubic one, not the umbilical one, because of the cervix is attached to the umbilicus. So the camera will be inserted and the trocar of the camera will be inserted in the suprapubic one, not the umbilicus, because there is cervix coming from the umbilicus. Okay. After laparoscopic adesolysis, the cervix is separated from the navel and the 10 millimeter pore inserted into the umbilicus. The uterine attachment at the anterior abdominal wall is sectioned to allow for repositioning of the uterus into the pelvis. The second procedure also includes a vaginal probe is inserted and the vagina will be opened with the use of monopolar energy. The cervix is introduced into the vagina and will be sutured to it with the use of polygalactine 2.0, which is the Vacron 2.0 separate suture. Once the uterus is returned to its natural position, the round ligaments are sutured to the pelvic side wall with the use of 3.0 non-absorbable suture like polypropylene non-absorbable suture. The broad ligaments are reconstructed by suturing them to the pelvic side wall along the natural course with the use of polypropylene. So we reconstruct the round ligament and the broad ligament, suturing the round ligament to the side wall of the pelvis with 3.0 non-absorbable sutures, and the broad ligament reconstructed and sutured to the side wall of the pelvis, okay, with also non-absorbable suture 3.0 suture like polypropylene. We'll do methylene blue test to test for tubal patency. This is very important, okay? Chemoperturbation or methylene blue test to know if the tubes are patent or not. And the patient can be discharged a few days after surgery if she is doing well, okay? Of course, if there is, for example, rectal cancer, the operation can be done during second procedure before completing the operation, as I said, okay, like excision of the part, including the tumor, then reanastomosis, then the procedure as I said before. And you can get the part excised of the rectum through an opening in the vagina and the continue repositioning of the uterus as I said before. Okay, this is in case the case was rectal cancer. Okay, but there is surgical line of treatment like this. Okay, according to Ribeiro et al. 2024, what about the result of this study published in 2024 by Professor Ribeiro? A total of 18 cases were reported to date. Patient median age ranging between 3 up to 38 with median age 29 years. The median time of uterine transposition to the upper abdomen was 150 minutes. And for organ reimplantation, 90 minutes. So the first procedure, the median time was 150 minutes. The second procedure, 90 minutes. Cervical ischemia occurred in 5 cases, constitute 27.8%. And this cervical ischemia, the most commonly reported complication. The median follow-up time was 25 months, and the 3 patients achieved spontaneous pregnancy, resulted in successful gestation out of 5 patients who were reported as having tried. So 5 patients tried to be pregnant, 3 of them got pregnant, and it was successful gestation. Okay? 1 patient experienced recurrence of malignancy. The conclusion of the study of Ribeiro et al. 2024, uterine transposition is a feasible and safe surgical approach that offers patients undergoing pelvic radiotherapy an option to preserve gonadal and uterine function, with the potential for spontaneous pregnancy. Okay, this is the conclusion of Ribeiro et al. 2024. What about systematic review by Pavon et al. 2024? Uterine displacement techniques should be further evaluated. So this is the conclusion of the systematic review of Pavon et al. 2024. They concluded that uterine displacement technique, whatever transposition or ventral fixation, should be further evaluated as a fertility sparing approach in young rectal or anal cancer patients. The reported obstetrical results are not yet sufficient to draw solid conclusions. A prospective clinical trial on the assessment of uterine displacement effectiveness and fertility outcomes is needed. So we need more prospective clinical trials about uterine transposition or ventral fixation to know what about the fertility outcome. Okay, so this is as regard the systematic review by Pavon et al. 2024, in which they got the result of operations of uterine transposition and operations of ventrofixation. And this is the end of my lecture today. I hope it was helpful for you. This is my books published on Amazon. I have now 7 books published on Amazon. The most recent one is Update in Obstetrics and Gynecology. The other one, Textbook of Obstetrics, Textbook Gynecology, Contraception Handbook, Multiple Choice Question Book, Medical Disorder in Pregnancy, and the Gynecologic Oncology book. My site on Amazon here in red, and my site on YouTube in blue, where you can find many lectures and OB guide, case scenario discussion, guidelines, ask station MSQ, okay, and another scientific sign on my blog, some picture of my operations and some articles. Please go to my sites and you may get benefit from them. Thank you everybody, wishing you all the best.